Hi, good evening everybody. It is my great pleasure and honor to be interacting with Professor Macut, who is the Professor of Endocrinology and Medicine at the University of Belgrade, and it is an absolute pleasure to have you over here, sir. Good evening, a very good evening to you. Sir, I heard a fantastic lecture just now. I mean, we really gain a lot of insight into your perspective and viewpoint as far as the metabolic and other issues are as far as other issues are concerned with PCOD. Sir, I would want to know from you, as a clinician, what is your message to all the physicians in India out there?
Thank you very much for the kind invitation to be with you after the lecture and to possibility to talk about the PCOS as a very common disorder in the population of females. Actually, the incidence of the disease is very high, and if we use the Rotterdam criteria from 2003, we can go up to 24%, which means that we have really a huge proportion of young ladies and those in the reproductive area or the reproductive period that are suffering from different problems, from the side of menstrual irregularities toward the metabolic problems, but also to the fertility needs. But as we are endocrinologists for the adults, so we are facing with many metabolic issues that you can heard also today, and mainly this is related to the insulin resistance related diseases like the glucose impairment or the impaired glucose tolerance leading toward the increased really percentage of type 2 diabetes and the later consequences. So we are talking about the metabolic syndrome that is very similar to the polycystic ovarian syndrome. And if we are talking about the overlap, we see a huge overlapping between the two syndromes that are starting from the obesity toward the cardiovascular outcomes, or we can say cardiometabolic outcomes. So with those women, we have the patients for life. Because we should treat first the menstrual irregularities like the oligomenorrhea or maybe the secondary amenorrhea at the beginning. Then we should have the problem with hirsutism. That is really a big psychological problem in the youngsters. And we have to address that in the proper way by including the dietitian. We have to include also the psychologist.
Okay.
And I think we should have the special multidisciplinary teams and a separate outpatient clinics for these specific conditions, because in that way we can really manage properly everything that is going outside of that. And first of all, in those younger years, it will be related to obesity and really some psychological deterioration, in the meaning that they are going more inside them, that they are suffering for depression, slight depression or really depression, and instead of getting some psychiatry drugs that could worsen the hyperandrogenism, we can help them by simple measures on one side. On the other side, we have to use the measures of the reduction of the problems related to obesity or to solve the insulin resistance syndrome, because out of this syndrome we have lots of problems with the dyslipidemia, increase or elevate glucose, either as the fasting glucose or the glucose after the OGTT, with hyperinsulinism and insulin resistance, and then later type 2 diabetes. You can hear today that there is a lots of transformation of those patients metabolically from the unstable disease toward the type 2 diabetes. And that is really sure if you have a young patient that has the impaired glucose tolerance once upon a time in the life, irrespectively how long we are following them, for instance from 6 to 16 years or maybe longer, they will definitely develop type 2 diabetes. So we have to think about that, and hopefully we are coming then to the area of diabetes. We should not treat the simple diabetes only, but these are very special conditions and special diabetics that we have to analyze and to tailor therapies toward them by using, for instance, lifestyle intervention. It is not very helpful if you do not include the other measures, and then to switch very, very fastly or maybe immediately toward the insulin sensitizers that we have a few in the field. And then to use some new modern intelligent therapies, I can say, like the GLPs or maybe SGLT2 inhibitors that are really coming to the field. And I'm really very excited about the future of the treatment of those ladies in that way.
So, if I get it absolutely right, what we are trying to say is that if we are able to treat our PCOD patients much better, much earlier, we would potentially contribute to a reduction in the epidemic of metabolic syndrome and diabetes that we are seeing. And this is a population which, if we treat, it's a complete spectrum that we would be treating. And at every age, there's a different requirement for the patient. For example, a younger patient would have more issues like, as you mentioned, oligomenorrhea. As they grow older, it would be concerned more with fertility. And as they go still further, it would be concerned more with metabolic issues, diabetes, and the rest of the issues that you mentioned. So what we are talking about now is a continuous spectrum of management for these patients rather than looking at them in isolation. And potentially a sitting population which, if we treat right, we could definitely contribute to the reduction in the epidemic we are facing. Is this what we would...
Exactly what you said. So if we count, for instance, if the half of population are women, and if we have about, let's say, 15% of incidence, so can you imagine, can you count how many possible patients you could have? So if we do not have preventive measures that are extremely useful in this group of patients, then we can solve a problem by reducing the number of later metabolic unstable patients. Like we can talk about the hypertension also. You've heard today also that there are lots of them that are switching into the hypertension, and especially if we have, for instance, already diabetics, like type 1 diabetes, the PCOS is almost unrecognized condition with the type 1 diabetes, and we have much more prevalent cardiovascular outcomes. So we are not talking about only metabolic aspects, but we are also talking about the later developed cardiovascular unfavorable outcomes, which are really important. So we are working in the long term against diabetes and in the long term against the cardiovascular outcomes. These are the metabolic or endocrine aspect of the problems. I'm not talking about the fertility needs.
Okay. So there was just one last quick question which I wanted to understand for you. I mean, sometimes there's a perception that maybe PCOD is also overdiagnosed. There is a little perception about that also. I mean, would we use the Rotterdam criteria exclusively, or would you want to add some light on that? Because, you know, there are so many people dealing with diabetes. As you said, it's a multidisciplinary issue. So often it happens that patients come to you with the diagnosis of PCOD, or somebody, the dietitian has told them, no, I think you have PCOD. So I just wanted a little more clarity. The message should go right across that, you know, what exactly is that you would look for when you say, okay, this patient has PCOD.
Well, this is an excellent question. And now we are coming to the core of the diagnosis. If we are not aware that our population of doctors that we want to transfer the information toward are not very clear with the diagnostic approach, I would rather use the Rotterdam criteria maybe to have a huge spectrum. Maybe they have to have an idea what should they analyze, and then when you got some experience with that, then you have to narrow the diagnosis and to make the filters how to come to the right phenotype, which is the lean PCOS, including hyperandrogenism and anovulation. That is the NIH criteria. So my suggestion is, for the beginning, let them just to analyze what kind of patients they have, even if they just discovered the polycystic ovary.
Fair enough.
If they have a polycystic ovary, well, let's see. Do they have an ovulation, regular cycles? What are their needs? What is your problem? Maybe they have to ask. Then they will come to the issue of the proper diagnosis. If they after the introductory training.
Okay, fair enough. That was great, sir. I think we've got the message across quite well, sir. And it was an absolute pleasure to learn from you. Thank you very much. Thank you.